Before we begin, all of us at the Medical Society Consortium on Climate and Health respectfully acknowledge that our advocacy, education, our learning across the country takes place on the occupied and unceded lands of many Native American tribes. To acknowledge this land is to recognize its long history and our place in that history. It is to recognize these lands and waters and their significance for the people who've lived and continue to live in this country and whose practices and spirituality were, are, and shall always be tied to the land and the water. Today's webinar is the 9th in our 2024 Climate and Health Equity webinar series as part of the Climate and Health Equity Fellowship Program. The CHEF program recognizes the need for more diversity in climate and health leadership and a sharper focus on equitable climate solutions. The goal of the fellowship is really to empower doctors of color from communities that face greater burdens from climate effects and are underrepresented in medicine to become the leaders in climate and health equity education, advocacy, and policy solutions. I'm Dr. Venice Curry, the Associate Director of the Climate and Health Equity Fellowship. Also joining me from the consortium to run this webinar are Dr. Shanita Johnson, Executive Director, Fellowship Director, and Dr. Kimberly Williams, Director of Operations and Strategy at the Medical Society Consortium. Our team will be available throughout the webinar through the chat to answer any technical questions and also to accept your questions during the webinar. The webinar series is hosted by the Medical Society Consortium on Climate and Health. The link is in the chat for you to review. It is held 1 hour on the second Friday of each month from 3 o'clock to 4 p.m. Eastern Standard Time. Today's webinar will be recorded and made available on our YouTube channel and our website for future viewing as part of the Equity Resources page on the consortium's website. This year, we are excited to continue to offer CME credits for our webinars, and instructions on obtaining credit will be provided at the end of the webinar. Today's webinar is on mental health, as mentioned, and mental health has not only become a more widely discussed topic in society, but also in conversations around climate change. As we expand the conversation, it becomes critical to really explore the link between mental health, psychiatry, and climate change, considering it through a health equity and a community lens to address the root causes, the implications, and of course, actionable solutions. Today, we are really honored to have Dr. Jessica Isom, Clinical Assistant Professor of Psychiatry, owner of Vision for Equity LLC, and a 2022 Climate and Health Equity Fellow graduate. Rather than using our time to talk about her many accomplishments and impressive work, we will place a link to her bio in the chat. At this time, we want to open, let me just tell you the general format for today will be that we'll have this presentation followed by questions and answers from our audience. We ask that you put any comments or questions or links to any resources that you may recommend in the chat at any time during the presentation. We will get to as many as we can during the Q&A. Please, we ask that you keep yourself muted so that we are not interrupted by any background noise. Dr. Isom, welcome, and we thank you for being here. You may begin.
Thank you for the introduction. I will get started. And it's definitely a both strange and humbling experience to be here as a former fellow, now talking to current fellows. And I feel this sense of having both the mentors here and wanting to be impressive for them, and also to represent myself transparently as a person who is still in a developmental journey for CHEF fellows as well, who are currently in the program, that there's still a lot of learning to come after the fellowship. And at the same time, it's really cool to be able to demonstrate what's already representative of growth in the talk that we're going to have together today. I'll name, as far as my positioning, the kinds of things that are informing how I've structured the talk. One, I am a community psychiatrist and practice in a community in Boston called Dorchester. So a lot of what I've thought about in thinking about the connection between this topic and the Chef Fellowship was, well, what would be useful to talk about for the people I serve? Patients who are often navigating a lot of complex social determinants while also navigating current representations of climate change and climate disasters. And then two, I wanted to think through, well, what could folks take away from this that could be useful for what they could do in their own spheres of influence. And some of these things are very possible as an individual. Some of them require more collaboration or connection with other groups. But I think it represents a menu of things that folks can walk away with and feel empowered to do. So I'll start with naming I do not have any disclosures relevant to this talk. And as far as where we're going to go in the time that we have together, I'll start out with some background and historical context. I'll then transition to talking about some of the links that we know between climate change and mental health. I'll then talk about a way to think through what some equity-minded intervention focus areas could be for us as clinicians, and then name some action steps that we might take before, during, and after climate-related disasters. And then I'll close out at the end with a Q&A. And I aim to leave about 10 minutes for that portion for this larger group. Some of this will look very familiar to Chef Fellows. One, what is climate change? And it is a long-term change in the average weather patterns that we see. It's come to define multiple aspects of our experience, both that are proximate to us and also distal from us across the world. And it is a concern for the present and also the future, and also one that we can do something about. And the spirit of that is why we are here. It's also important to note that there are lots of different ways to have this conversation because it touches so many different aspects of human health. And you can see that represented here. This is an image from the CDC. In the center, you see a representation of how we might have conversations about different components of this, from rising temperatures to the extreme weather that we're seeing, to rising sea levels, and then increase in carbon dioxide in the atmosphere. And then as you go around the periphery, there are more specific examples of what the consequences of that can look like. And for our discussion today, it might seem like some of it will just be focused on that one phrase to the left. It says mental health impacts. And at the same time, so much of how people function, both in a non-pathological sense, such as just having stress and some anxiety, to a pathological sense, such as managing a diagnosable condition, is very much connected to all the other things represented here. So there's an intersection between a person's symptom burden from asthma or cardiovascular disease and their mental health. So there's just so much connecting and overlapping there that we can pay attention to. And at the same time, I'll be offering some very specific threads that you can follow to understand the connections later in the presentation. In spaces, what I've done in general with this concept of equity is try to drive it home, no matter the topic. And that was the spirit in which I joined the Chef Fellowship and greatly benefited from that experience. It's another way of using an equity lens to expand the conversation and the focus for interventions to the margins. In that experience, benefiting from the foundational knowledge, and also the role modeling of how that's done, has been really crucial and has allowed me to connect some of the things that I think about just in my psychiatrist role to how we might think about this conversation of climate resilience for folks that we're working with. And one way that's connected is in thinking about liberation psychology. And one really useful framework I've come across in helping healthcare professionals conceptualize how they might approach a person in a way that's not rooted just in traditional forms of how we do that is this liberation health model. And it's represented here as a liberation health triangle. And what this is about is drawing upon liberation psychology and all the scholars historically and present day to say that the way that we think about a problem needs to be expanded and inclusive of the factors that you see here. So if someone were to name, for example, I am concerned about the ways that a potential climate disaster or one around the corner will affect me, that is a problem. And expanding how we think about, well, what does this person need from us as clinicians should include these considerations here. And at the top, some of that is just their personal factors, who they are, their background, things that they're dealing with on a personal level, inclusive of a health condition or specifically a mental health condition. And then at the bottom, you see represented what we often don't talk about as much. What are some of the institutional factors that they'll have to deal with related to, in this case, a climate disaster? How might they, for example, experience pursuing some kind of disaster relief? We'll talk about in detail later. And then how might they experience that, not just at the level of how do I get it and get access to it, but how I be treated, for example, in navigating that specific institution. And then there are cultural factors at play too. And this is more about how does the world experience me as who I am and treat me based as who they think I am. So if I were to show up in a space, for example, maybe as the community was recovering from a disaster and I am who I am, what might I have to navigate to be a part of that group, a part of that recovery effort, a part of just finding a new life for myself, and just making sure that's a part of the conversation. And then our job as clinicians in this model is to figure out what are some action steps we can take in support of that person that we're working with and our community. And then also what are ways that we might pay attention to what people are saying to identify some internal work they might need to do. So those kind of elements will be a part of this conversation as we continue. And I'm looking forward to that being a way of thinking about this a little bit differently beyond just providing people material resources. So I wanted to name that climate equity is really refreshingly becoming more of a conversation and also a structural part of how institutions are functioning. So one example of that is FEMA's come out with a post-disaster guide for local officials and leaders that focuses on what equitable recovery can look like. And while it's really lovely that these resources exist, it's also important to name that they're pretty new. So a lot of what we will be navigating in spaces is the novelty of that. There are ways of doing things that have existed for a very long time in this space, and we're infusing that equity lens and types of interventions in a way that might be experienced as by lots of people as completely new. So the cool thing I've experienced in the past few years is being able to draw upon resources like this to understand how the thinking has evolved and get a sense of what climate equity means at multiple levels. So I would encourage folks to check out that report, especially since right now in different areas, but most presently in the Southeast, there are folks who are experiencing this right now, navigating what post-disaster recovery looks like for them. I also want to name too that in a conversation about mental health, there is a way of talking about it that focuses on mental illness. And if you look in this graphic, that's represented as the x-axis, the horizontal line. And we do need to think about folks before, during, and after a disaster experiencing a high or low symptom burden from a diagnosable condition. That is important. And at the same time, the entire human population is represented in the y-axis going up and down, where many of us might be languishing and many of us might be flourishing. And the ways that that shows up for us very much is connected to the societies that we exist in and also our positioning in those societies. So we have to be thinking about the groups that might be more vulnerable to having a constant experience of languishing. And I can name for myself in my clinical work that I work with lots of patients who, even when their mental illness or their symptom burden is pretty low, are languishing because of their circumstance. So in that sense, having a more textured conversation is important, just as much as it is for folks who have no diagnosable condition. And we still have to be thinking about, well, what might be contributing to them languishing versus flourishing, and how might that be relevant to how they prepare for, behave during, and then recover from a disaster. When we think about those groups that have more of a vulnerability to languishing before, during, and after, that includes children, that also includes the elderly. It also includes folks who are racially and ethnically minoritized, which is often referred to as BIPOC or people of color. Those that do have diagnosed mental health conditions, and specifically those with serious mental illness, such as bipolar disorder or schizophrenia, are more vulnerable as well. And of course, those who are low income or who have low access to wealth. And it's also important to name that there's intersections of positioning for folks that one person might represent multiple groups. And then what does that mean, how we might think about what to offer them. And just to highlight some of those intersections with a bit of data, if you look at the rates of chronic mental health conditions by race and also access to wealth, less access to wealth and also being a racially or ethnically minoritized person can lead you to having a higher rate of a chronic mental health condition and also poor mental health outcomes. And that's connected to both having access to services and also the quality of care received while there. Just some data on the right showing that your level of, or where you're represented as far as the federal poverty level is also, it's racialized. So when thinking about low income or low access to wealth groups, you're going to see that they are colorful in their representation. And that means that they are more vulnerable to having a condition such as depression. Recovering from that can be more difficult, can take a longer time. And for some folks may not happen at all because their access to traditional supports can be relatively limited. And that's across the board for non-Hispanic Black adults, Hispanic adults, and non-Hispanic white adults that some people have access and some people don't. However, it's more of an issue for folks, again, who are racially and ethnically minoritized. It's also important to note that children are a big part of the conversation too. For example, up to 30% of children can experience PTSD, anxiety, or depression after a disaster. And while we do talk a lot about the children, it's not often in our interventions that we're focused specifically on them enough. So if anyone here is interested in that component, there's a lot of work to be done there. Elderly themselves also are more vulnerable to specific parts of this, such as heat waves, and should be a priority group in that sense. And then folks that have severe mental illness, of course, as well, specifically in heat waves. And one way I'd like to think about this, in the sense that it can be really overwhelming to kind of metabolize, is that one person can't do everything. So in some ways, there could be some collaboration across different clinician groups to address these issues. In some ways, it might be helpful for a specific group to focus on a component of this, such as pediatricians, maybe partnering with primary care to address family needs, and you know, other parts of that. I think taking a population health approach and identifying what this specific population needs across the spectrum, from folks who are completely fine to folks who have risk factors, to folks who have diagnosable symptoms, to folks that have disorders, that has helped me, that population health approach, kind of figure out, well, what do I do with this information moving forward? So some key takeaways from this are just that what we know to be true is that social, political, and economic existence on the margins can leave you more vulnerable to mental health conditions, and that can be a risk that's compounded both before, during, and after a climate-related event. Not having what you need already increases the likelihood that you'll develop some kind of mental health condition, and that your outcome from that may not be ideal. And that we should be thinking about all of this as we're considering what do we do with our equity lens as far as our decision-making to be as responsive as possible. And now I want to transition to, well, what do we know about the links between climate change and mental health? And I'll say there's a lot more to be determined. And one thing I'll name that was really interesting in the past week or so is that we don't know, for example, very much about what does it mean to watch the news and see, not proximate to you, but distal to you, that a group is experiencing, maybe like a geographic group or areas experiencing a climate-related disaster or even about to. And as I watched the news for the two recent hurricanes, I thought about what they focused on in those news stories. And a lot of it, of course, was factual and real. And also there's a way that the news presents things that is sensationalized. And one of the ways that that showed up for me was how much did they focus on naming what is going to happen relative to naming what we can do to prepare ourselves, specifically from a mental health standpoint. I didn't see a lot of focus on how might we increase resilience before, how might we pay attention to things that can build our resilience during, and then what do we do in the after. And I thought that revealed itself in lots of ways, both for people who were in those geographic areas trying to figure out what to do, and also for observers. There are folks who are witnessing it across the country, likely also across the world, saying, I don't know what to do with this. And I do think if people were mobilized around that, the idea that there are things that can be done to kind of prepare for these and get people through and offer a specific type of support from a mental health standpoint, that it might have been a more productive use of all of the airtime these two hurricanes were getting on the news. So what do we know? We do know that climate change related hazards and also threats that we're experiencing over a longer period of time are meaningful. And in that sense, they contribute to these exposure pathways that we know lead to some adverse mental health outcomes. So when we're dealing with things such as air pollution or food insecurity, disruptions to the supply of like pharmaceuticals, medications, when folks are being forced to migrate to different areas, when we're losing things around us, and then also over a long period of time when we're witnessing these changes as our awareness is increasing, there are consequences to that we have to pay attention to. And those are elaborated on here, and I'll leave this here for folks to be able to go through this in the recording, but I won't dwell in the interest of time. This is just some elaboration from the World Health Organization on what some of that can look like in more granular detail. And to pivot to what those outcomes are, you see those listed over on the right. Stress reactions, very clear, very apparent, just again in the past couple of weeks with the 2 hurricanes. Strained social relationships are a big part of this too. Folks can have a worsening of their existing mental health condition or experiencing the onset of one they hadn't had before, particularly around stress-related conditions. A lot of emotionality is around feelings of helplessness, dealing with fear, and a lot of grief. And that, conversation around grief is such an interesting point to focus on, because we do know a lot about what to do with grief. And yet in our messaging, in our disaster-related communication, we are often not providing folks with that information, both information that could help them to anticipate the grief that they'll experience from their losses, and then also what to do as they're experiencing it to kind of both manage it and recover. There's also a lot of connections between this and suicidal behavior, substance misuse, and then there are emerging diagnostic labels that are being applied to experiences of climate change, largely interesting for folks who are younger in age, who will experience this for a longer period of time. And again, here's some elaboration on what that can look like, and I'll call out a few. There's intense emotional suffering that can come from having those stress reactions, and the physical health problems that can come from that. And again, that makes the point that there's a connection between mind and body. What we call physical health versus mental health, really, there isn't much of a distinction there. There's lots of overlap between the two that could create space for a lot of clinicians of different types to be a part of this conversation. Increased risk of suicidal behavior is important to name again. There's also the social relationships in the form of being separated and just being disconnected from your support systems, which can affect your resilience related to a disaster. Folks that have mental health conditions that are already languishing, having to deal with this, of course, can worsen their symptom burden. And then a lot of people are dealing with that helplessness, that fear, that grief, and not everyone has a sense of what to do with that. So key takeaways here are that there's a lot of information that we do know about what the hazards are, what the threats are. We've already identified some direct linkages between those and mental health income or impacts, both directly and indirectly. And that can empower us to know what to anticipate or expect in response to what's happening chronically, gradually over time, and then what happens in these discrete periods where there's a disaster. And the question becomes for this next portion, well, what are some of the areas that we can respond to as clinicians that would represent an equity intervention? And again, I wanted to focus on areas that would be relevant to how I operate as a clinician in an FQHC, where there's a mix of patients, and at the same time, a lot of the patients are dealing with a number of social determinants. And these are the kind of things that I thought would be useful to know. To be of support to them outside of some of the really practical parts of this, such as making sure my patient has access to medication. While important, there are other parts of this that were illuminated for me in the past couple of years that I wasn't as aware of. So I'll talk a little bit about, I'll talk about some news stories that highlight these different inequalities that folks experience. I'll start with talking about the impact on low-income and minoritized communities. I'll talk about the evacuation and the immediate response, a little bit about displacement and housing insecurity. Then I'll transition to talking about aid itself, and then what it means to experience some of the other consequences, such as job loss and economic instability. So the first story here, this is about low-income and minority communities that are facing a higher risk of not having access to, for example, power. So the restoration of just access to utility services can vary widely. I saw a paper that for Hurricane Maria in Puerto Rico specifically, it was the longest documented as of the writing of that paper to get power back on and some other utilities. And it was 3 months up to over a year for folks there. So when we're talking about restoring power, you might be exposed to a very general surface level conversation. And what you could offer to that is, well, what are we specifically doing for folks who are more vulnerable to a longer delay in getting their power or other utilities back on? And then what do you do as a clinician working with folks to prepare them for that possibility and then support them through that as they are getting care from you? Number two, this story is about having challenges in evacuation and the immediate response after disaster. And a lack of resources can prevent people from leaving, which we see again widely represented both in the media and also likely in our community connections, in our own families, possibly as well. And then what does that mean, again, for our relationship with the folks that we're working with? One new thing I learned recently was about folks who are incarcerated. And this is from social media. And they were talking about this policy of essentially leaving folks in these settings where they are incarcerated and asking them to fend for themselves. And then allowing staff in those facilities to evacuate at a certain point is a part of the policy response, but the folks in those facilities are left there. So I see different people having different parts of this conversation, both for folks who have more autonomy and freedom and for folks who have very little in that example. Some other things to consider are that your patients or community members might be experiencing just the consequences of displacement. Lots of stories connected to this. There's one article here that talks about land loss and liberation, highlighting how there are specific indigenous struggles connected to land and that kind of relationship there. And then also about how folks may, at some point, for example, have the resources to come home, but are dealing with the lack of resources to make their residence livable. And then what do you do with that? I am in communities where the conversation for some is, how can I make more money to pay for the repairs to my housing? And of course, that's coming from a person that has access to more job security, more job options, and an ability to expand their income. Very different conversation for a patient I work with, which likely will be around, I don't have very many options, or where can I go to get resources to help? And that word to go question for me at some point was just, well, ask the authorities. There's resources out there. They are available. And I've developed a more nuanced appreciation that they are not equitably distributed. So this story is about federal aid favoring folks that already have more access to wealth, often connected to property value. So you have two houses here, kind of in the same area of Louisiana. And after a hurricane, both homes were damaged similarly. And the person on the left received $17,000 for their repairs. The person on the right received $7,000 from FEMA. This was before those changes that were reported in that report that I believe came out in 2023 from FEMA about equitable aid across the board. So maybe that would be a different experience for folks now who are pursuing FEMA aid. However, I imagine there's probably still a lot of work to do there. So in this conversation, as a psychiatrist who already does a lot of advocacy around navigating institutions in general, it just adds another element of consideration if I'm recommending a person pursue this, that their experience of this, of course, can be connected to inequity. And then how do we support them in knowing what to do, and also prepare them for a response that might not be as useful as what they imagine. And again, once we are recommending folks to go to the place that's supposed to help, we have to consider, well, what's going to happen when they're there. There's language barriers that might arise when they're trying to get through the application, literacy challenges as well. There's also been documented a lot of rejections come from submitting applications. What does that mean for a person who, again, is already languishing, already maybe feeling demoralized, not having a lot of hope that their first application is rejected? And then what does it mean when they find out that most applications are, not most, a large number are rejected? So one story talks about 46% of people who sought help since 2022 being rejected. So again, how might we prepare people to be resilient in the face of pursuing that process and then navigating the consequences that come from that? And then, of course, it's costly to navigate these situations, and there's a lot of uncertainty for many people around what this will mean for them. We could offer people all the practical steps in the world, and a lot of what we're not able to offer individuals ourselves, at least as clinicians, are material resources. So we might be supporting folks through loss of job, a lack of options to pursue further employment, mounting responsibilities that they'll have to navigate for themselves and their families. And there's something to that could be a part of our conversation about how to be useful to them from a mental health standpoint. So just some key takeaways from this are that When thinking about this more deeply, what's happening before, during, and after a climate-related disaster, there are lots of ways that societal inequalities and inequities can have an impact on mental health and well-being, and that we have to be thinking about what people will be facing, what they are facing now, what they will be facing moving forward, in order for us to figure out what kind of responsiveness would be of use. And it's not necessarily always going to be about the direct relationship between us and this person. A lot of it can be around the advocacy efforts that we engage in, such as naming some of these things as still being a challenge, for example, in op-eds, or submitting any kind of policy a resolution or some other just form of elevating this, both as a topic and also some solutions to address it. And that brings us to what can we reflect on? What kind of action steps can we take that could be supportive? And again, I encourage folks to think about what at a surface level could be really useful. And then also how might we, kind of tweak things to be helpful from a liberation psychology lens. And one way that shows up can be, you're not just asking a person to apply for aid, you're asking a person who may have a pretty high level of literacy around how inequity works to try to engage with an institution that has historically been and present day is discriminatory. So like what kind of conversation might we have as clinicians with that person? That's kind of what I am thinking about when I say liberation health model. How might we tailor our communication and our approaches to acknowledge the reality of the ways that people have to exist? So I'm going to start this off in a way of offering just overarching tools that we might think about exploring more and then also making use of. And then I'll offer some specific suggestions for things that we might do. And then I'll open up the floor from there. So bear with me. And the two tools I thought would be interesting to share would be one, the disaster communication intervention framework, because I liked how it broke down some opportunities for how we might think about communication as a public health intervention. And again, it's more of a critique of the news media and how they could do things a bit differently and how they use their airtime to have conversations with us. And then I wanted to show psychological first aid as one example of a tool that can be used within that framework. So on the left is a representation of what that framework looks like. There are pre-event aspects to it to prepare people. There are components of it that are about what you do during the event or shortly after. And then there are components that are about the recovery. And a lot of what could be done before the event even happens is connected to resilience. And a lot of that can be around building relationships between community members and also preparing them for what they will experience as far as disaster-related distress. There is a way of just naming the problem and not connecting it to sort of a preview of what to expect and then what to do that feels very unhelpful as far as how the approach was done in lots of larger media spaces in the last couple of weeks. The event response can be focused on, well, these are some things that you will need or things that you might see in your community in connection to this disaster. One really important part here was that we should be focused on demonstrating concern and empathy. There are lots of people who are always receiving concern and empathy in response to a terrible thing happening to them. And there are lots of people who don't. And a lot of our messaging and communication can fall short when we don't name that we do have an empathic connection to what's happening to them. And for example, that might be around folks who were incarcerated during the disaster, meeting them with some concern and empathy after the disaster has occurred to kind of offer them something that could build their resilience in contrast to what they typically likely receive. And then post-event, there's some suggestions here on figuring out where the community is at that time, as far as the response, when have they transitioned to recovery, and how might we, for example, build some kind of narrative around what happened to us. And that narrative should both highlight what happened and also what the community did in response, which can help folks heal from that experience. And it's really easier than one might imagine to do that, because post-disaster, we are often the most pro-social versions of ourselves. We're often naturally helping each other restore the things that we need to take care of ourselves, much more than we do in everyday life. So there's a lot to that narrative for that community that could be drawn upon just by asking people what do they see, do, or participate in post the disaster. On the right, I'm showing this to just identify what kinds of interventions are useful. And a lot of these all of them actually, are very accessible to a layperson. There's training that you can receive. I think it's 6 hours or so to feel more confident and credible to do this. And at the same time, a lot of what we need represented here, a lot of people are likely already doing it and could do more of. I want to call out hope and connection as two things that are really important, especially as the frequency of these climate-related disasters is increasing, and also awareness too. More and more folks are, in my experience, accepting the reality of this being a thing. And I think a part of what is needed now is for that section of the demographic, arming them with things that rise hope in their lives, and also encourage them to seek as much connection as possible to be as resilient as possible. And I'm going to close with, in the last 10 minutes, just some ideas. And these are ideas that are mapped out that represent on the left what community resilience can look like. And then on the right, they're split out by what strategies represent adaptation and which ones represent mitigation. And then they address these social determinants that you see represented here in the middle. Some of these are specific to mental health. A lot of these are just the social determinants of health. So they're going to seem very familiar in that sense. So what we're thinking about as far as things that we can do would be things that improve social connectedness, things that help us hold governments at multiple levels accountable to what people actually need. We could be thinking about how do we make sure we communicate risk effectively? How do we prepare people for what's going to happen by making sure they're as healthy as possible before that thing happens? And then how do we support people during and also after as well? Briefly, mitigation strategies help us to reduce or prevent what's happening at this time by slowing the progress down, giving us more time to have a healthier relationship with the world that we inhabit. And a lot of these are around reducing the carbon footprint, for example, and conversations we might have in our healthcare facilities. It also could be around the advocacy work that we might do. So one suggestion could be focused around promoting sustainable healthcare practices. And there's a climate action incubator program that I'm going to start next week through my health center, because I would like to learn more about what this could look like on the ground. And when I say on the ground, I mean in a community health center that really does not have a lot of resources, that is, trying to provide patient care, dealing with so many different factors that make it difficult to sustain our presence in the community. And yet, what could be done? What's possible as far as reducing the carbon footprint? So the end of that program involves you as a fellow drafting a proposal to the executive leadership and pitching some suggestions for what they might do. And I'm just very interested, again, at the level of a community health center and what that could look like. Are there things that are achievable that can integrate into how this system functions and also with the resource that it has? So while that can look like an individual doing their due diligence, it also could look like a green team within a facility doing their due diligence together and figuring out what kind of things internally could be done, and also what could be recommended to others. And a lot of what that looks like for services could be around using web-based programs, making use of technology, and at the same time, technology is not equitably distributed. So we definitely need more ideas than just that. I wanted to show some examples of how we might brainstorm ideas for carbon footprint reduction specific to how we operate in the healthcare system. And this paper identifies different roles, such as a general practitioner or a dentist, and then what we spend, how much carbon footprint we are contributing to based on the activities that we engage in. So if you look at mental health, for example, the largest dot you see for us is electricity and gas and some visitor travel. So one could argue that one thing we could cut back on is the need for patients to come in by maximizing use of telehealth services, and there's some evidence base to support that. We might also think about some of the other suggestions here, such as the vehicles that we make use of to get people to the clinic. I think we do have computers that shut down at night. And then this larger medication conversation is interesting too, because it's a little bit complicated, both in the patient experience of that, and also in the clinic experience of that. And I think it's an op-ed waiting to be written as a psychiatrist, because I've had reactions to what it means to force patients to receive a 90-day supply that were around clinical safety. And at the same time, there are benefits to consistency in medication access, and also, as represented here, carbon footprint reductions. So like, how do we navigate all of those pros and cons to create a kind of ways of prescribing medication and receiving it that kind of are balanced in that sense. So just a plug if anyone wants to explore that. Something else we might consider is education and advocacy, which is talked about a lot in the fellowship and beyond. I see this in communities already. In Boston, there are community-based organizations who are doing this work. What would be lovely to see more of is collaborations between healthcare professionals and those organizations to kind of cross-pollinate, and for there to be some bi-directional learning. And for me, for example, at Codman Square, that might mean getting a sense of what they're talking about in those spaces and using that to inform our understanding of what people feel they need as far as our response to, for example, a disaster. And it also might mean me sharing information that might not be present in that space as a way of contributing to the collective understanding of what people might be up against. There's also suggestions, for example, to do a green prescribing program, naturally likely a part of what we do in lots of different ways in healthcare already, maybe not named as such. So I put .rx here to represent a type of program that's not explicitly connected to reducing emissions or reducing our carbon footprint, but does result in that. So it might be helpful to just reframe some of the things that we already have in place, such as recommending folks to go to green spaces to get body movement in as a way of contributing to the changes that we need. That might help folks to feel more empowered just to name by naming what they're already doing, and maybe empowered to make other changes as well, since they're already kind of on that trajectory. So closing out with some adaptation strategy suggestions. These are focused around lessening the impacts of climate change that are already occurring or that are around the corner. Enhancing resilience is a part of this too, and just preparing folks to face what they will likely experience in the very near future if they haven't already. One part of this for us could be a focus on making sure that what we are putting out there is structurally competent and culturally sensitive. And a lot of that can be built around some opportunities. So for example, at Cambridge Health Alliance, there is a Climate Health Organizing Fellows program. That's really cool. They emphasize developing relationships as a cohort. So there's like a group of 3 people who commit to a project, and they're armed with some community organizing skills. And we have representations of people who do that even now here on the call. And it might mean or it might be represented as joining organizations who are already doing this work, and they just might benefit from more education from you, for example, as a chef fellow or someone just invested in this space. And what does it mean to have this conversation in an equity-minded way? Also, I've seen a lot of ongoing efforts in Boston that I wasn't familiar with prior to the fellowship that represent the work is already being done. And I think it's important to name that the work is already being done, because a lot of my training has been about inventing the wheel in lots of ways. And it's humbling to see that in this particular space, there might be some spaces where the wheel has to be invented. And at the same time, there are a lot of spaces where the wheel's already going and turning, and you could just join. Join, contribute, learn from. And one example of that is this Boston Climate Action Network. There are plenty more in the Boston area. They're doing the work already, and you can maybe feel less intimidated that exists and join that effort. And also, I think there's something about joining and just experiencing the growth that can come beyond the Chef Fellowship and just being in relationship with those groups. And a lot of them are very active. Something else to consider is you educating yourself on what does equity look like in recovery, and when you're in spaces, or maybe when you pursue a microphone that will allow you to talk about what that looks like, just speaking that truth to power, and maybe leveraging your positioning as a healthcare professional to allow people to hear you. It might also be a smaller scale, such as just you in the place that you work, the hospital, clinic, or other setting, saying, these are some of the things that we should be thinking about. And I think An example of that for my health center is that we do talk a lot about heat risk or extreme heat conditions related risk and what folks can do. And we've had less of a conversation around another risk that I'll show you in just a moment. So just adding to the conversation might be helpful. And again, like leveraging your voice. So that's connected to this next part, which is really being invested in seeking out information about, well, what are the risks specific to where I work or operate or the place I'm interested in? And there is a spectrum of availability of information. And fortunately here in Boston, it's pretty accessible. And I'll show some of that now on the next slide. They've done a work to understand which communities or neighborhoods are most at risk, and then to understand what those risks specifically are. So as I said, I work in the Dorchester neighborhood, which is the neighborhood of Boston. And you can see a part of it represented here is Dorchester Bay, the part that's by the water. And there's also some interior parts as well. And it was named as one of those 9 locations that needed flood protection interventions based on its geographic vulnerabilities. And they go even deeper in these climate-ready materials, and they tell you exactly what your risks are, and then they offer some suggestions for what could be done. And I noticed that in our conversations that I've been a part of, which I have not been a part of all of them, that we do talk about heat more than we talk about the flooding risk. And one of the things that could come from the work that is being done is just making sure, for example, if you're in a space, that all of it's being talked about in a balanced way, and that when we're coming up with possible next steps, we're being as responsive as possible to what the data is telling us the risks actually are. So I personally have questions down the line for my health center about what do we do with this flooding part as far as communicating the risk of it, preparing ourselves for the likelihood that it will happen at some point, and offering counseling to patients around what they should do. Also, providing mental health support is very important and needed. And I'll just show one example of that briefly before opening up the floor. And just to call out the All Earth Mental Health Alliance, an example of a group doing that work. They were formed in 2006, 2005. Post Katrina. And the objective was not just to respond to that experience, but also to offer resources ever since. And just shout out to Dr. Nell Prim, who's taken a really large leadership role there and has kept that work going. And you could refer to that website even now for some information for recent events. So as far as key takeaways, just naming that we can do different things. We can support folks in accessing resources. We can support investments through our advocacy voices and things that would help build community resilience. We can proactively create spaces for community members where they can lead and partner with us in figuring out what their needs might be, and then also arming them with information to help them prepare. And we can invest now in improving mental health, as well as really make use of what we know is useful during and after disasters to prepare people as well. I'll also show references, and the floor is also open at this point for Q&A. Thank you for staying with me.
Thank you, Dr. Isom. That was an extremely informative and valuable presentation. We do have some time for some questions. If you have questions, you may put them in the chat. We also want to remind you to please take a moment to fill out the webinar survey. The link is now in the chat as well. Your questions for Dr. Isom?
We have a couple of questions in the chat.
Okay.
And the first one that is from Charles Francis. What are things people can do to slow down climate change? And then the other one I see, I'll give you both. Is climate change having an effect on immigration into the USA?
Great question.
So I'll say for the second, I don't know the answer to the question. I would wonder how displacement globally is affecting the patterns of migration. I would wonder, it'd be a question. And I would imagine that in lots of ways, there is an incentive to be in a place that has more resources to support folks before, during, and after disaster. So that might lead to there being more of an influx of folks because we do exist in that privileged position in the United States. But I would defer to more of a policy expert on that to answer that question. And then what are things we can do to slow down climate change? A really big question. I would say I would first refer folks to the wealth of resources available through the consortium, where folks have dived into that in very nuanced ways in different spaces. I would say sticking with the healthcare conversation, I believe there's more of an opportunity to identify how what we do is having an impact on this issue, and then what parts of that are modifiable. And I'll give one concrete example. There are patients who make use of transportation services to access care at the health center. I have recommended in the past for a person who has an issue with being in proximity to others, that they be offered the opportunity for a private ride to come to the health center to make sure that individual person could make their appointment. In retrospect, if we're having a conversation about climate change, that person having access to that individual private ride is going to have an impact on our carbon footprint, the emissions that we're experiencing, and the overall gradual changes that we're seeing. So I would need to be more creative about how I would pursue a solution to that problem in respect to climate change. As a clinician, I also might think about my prescribing, another part of what I do, and how that's a part of this conversation. And then also the center I work within, how might the organization do things similarly or differently to address climate change as well. And that same process of working through how do I operate as an individual and what is my impact and what could be different could be very personal as well. And the things that you do every day, as far as consumption, as far as how you make use of water in your home, how you manage food and its availability and waste. There's just so many spaces that one could go in response to that question. So I would identify what my personal impact is personally, what is my professional impact, and then where are spaces in there that I could pivot to reduce how much I'm contributing and others around me.
And following that question, what can physicians do collectively to improve the resilience of communities to climate change?
Yeah, I would say two things. One, as a part of what we do to increase community resilience to a lot of issues, there's a lot of overlap there. One would be building relationships so that we have a clear sense of what folks are dealing with, like what their challenges are. And then in a general sense, and then we can leverage those relationships to be specifically helpful. And that means going outside of just the clinical encounter to build those relationships and maintain them to be of use. And then I think both in the clinic and outside of it, we have a lot of access to information. We often have really high levels of literacy and comfort with that information. So I think representing it in a way ourselves that could be really helpful to build community resilience is a part of it, or aligning with other spaces. So I talked a lot about the media, for example, as one avenue for that. So it could be developing your own voice and then using it to share that information on platforms as large as, CNN, Fox News, other stations that have a very large audience. And as a physician or other healthcare professional, you do come with a lot of social status. So a lot of it could just be translating information to folks directly in your community. It could be expanded to using your voice to access larger microphones to share information as well. And then just maintaining the kind of relationships that keep you in the loop to be useful when things are actually happening in your community as well.
Thank you. Thank you, Dr. Isom. I know that this discussion can really go on much, much longer, but we do need to wrap up this session. I would like to thank our speaker again and to thank all of you for participating in our webinar series. I hope that you found it useful. And as a reminder, these webinars are held on the second Friday of each month. Our next and our last webinar for this year will be on November 11th at the same time. We will cover healthcare system sustainability. Before you leave, we ask that you take a moment to complete the webinar survey if you haven't done so already. The link is in the chat. And as announced at the start of the webinar, we are pleased to offer CME credit for our webinars. So to claim the CME credit, please follow the link in the chat or scan the QR code that's on the screen right now. Follow the directions on our website. Today's activity code to claim CME credit is 13350. Again, that is 13350. We would like to thank our sponsor, Johnson & Johnson, and this really now concludes our session. Have a great day and have a great week.